as I say to people, we get into a bit of a fixed mindset that this is going to be the be all and end all, but no one knows what's around the corner.
Yeah.
And so, you might be run over by a bus,
yes,
or
you
might something completely
health
unexpected
event
might happen.
Yeah, that's true.
We can't predict the future.
No.
And it's all about empowering the person, giving them good information so they can make good decisions going forward.
Yeah, totally.
Kia ora koutou, and welcome back to this Dementia podcast series. The next session we have is hosted by Dr. Darren Malone from Tauranga. So he is going to host what we are calling a deep dive into all things clinical around dementia. He's joined by two of our kaimahi workers here from Rotorua, and please enjoy this session. It does take a bit of a clinical view on what dementia is, so please enjoy this time. Kia ora.
Okay. My name's Darren Malone. I'm a psychiatrist for older adults. So that's a medical doctor who then specialises in memory, anxiety, pain, sleep, depression. And I've worked in the area of dementia and cognitive impairment for probably about 18, 19 years. Worked at Rotorua Hospital here for 15 years, and it's good to be here.
Thank you, Darren. Kia ora, I'm Carol Fisher. I've got a nursing background. I've been involved for about 30 odd years in the Rotorua area in terms of supporting dementia services where people are living at home. So living at home for as long as possible and making that a quality of life for everyone that's affected by the dementia journey. And so my passion is certainly making sure people don't have to go that road alone. So thanks for the invitation today. And Tania is one of our lovely frontline workers.
Hello, so my name's Tania and I'm a dementia advisor. I'm a registered nurse of over 30 years, and I currently work for Dementia Lakes, and previous to that I was working in a memory clinic and a needs assessor, so that's aligned pretty well.
Where did you work in the memory clinic?
With Michelle Bloor.
Okay, great.
Yeah.
All right, so we're going to talk about dementia versus normal aging. And what I would normally say to people is that as you get older, your memory should be reasonably intact, similar to what it was in your 30s and 40s, and that if your memory significantly declines when you get older, then it's because of a reason, that something's going on. When we get older, our memory may be a bit slower. It might take us longer to remember something, or we might have some mild difficulty finding the right words for things, so people might have a tip of the tongue experience, but we should be able to name things and remember things reasonably similar to what we were when we were 20 or 30 years younger. So a dementia would be a clinically significant decline in one or more cognitive domains, so that might most typically memory retention, so learning new information, remembering what you had for lunch yesterday or what you did last week, and the memories for things that we've experienced in our lifetime. Our episodic memory will generally remain intact with someone who has a dementia syndrome. What's your experience in terms of trying to differentiate between normal aging and dementia? Have you got any pearls?
I think it's always a concern when people, certainly you hear comments of carers in particular or other family members will say things like, am I concerned they might be getting dementia if they've got memory, sort of little impairments, but it's reassuring them for those very things you just said. If you're remembering, there's certain characteristics. So it's reassuring people that there is a little bit of difference with aging, but if there's marked differences, there's something happening.
Yeah.
So it's just reinforcing that with people in a way that's reassuring them, but also saying, just watch for red flags. Yeah.
Yeah. Or people, when they go into a room, and they've gone into a room to do something, say you're in the house, I'm going to go into the room and get this or that, and a person with dementia, who's maybe got dementia, has gone into the room, and the difference between someone who's just getting older, they've gone and they forgot what they were going to go in for, so the person who is just more normal aging backtracks and replays what they were doing, and then, that's right, I was going into that room to get that. Whereas a person who maybe have dementia, they will go into that room, completely forget what they've gone in for, not even think to backtrack, and just go on and do something completely different.
And I guess there's different types of dementias. So the most common by far is Alzheimer's dementia type, which would typically start with a very gradual decline in memory retention, and can also be associated with problems finding the right words for things, sometimes problems with calculation, arithmetic, and then there are other dementias which may be associated with other medical comorbidities like vascular dementia following strokes or lots of TIAs, dementia caused by alcohol use or abuse, dementias associated with other conditions like Lewy body dementia, and then there's frontotemporal dementia, which usually would start a bit earlier and would typically herald itself with a change of personality and behaviours rather than memory. And one of the reasons why we encourage people to come forward for an assessment if they're worried about their memory is that there are a number of differential diagnoses which need to be considered and excluded, and importantly those differential causes for memory decline can be very treatable. So we're talking about depression, which can present with significant problems with memory. You can also have organic conditions like hypothyroidism, deficiencies of vitamin B12, and again, if you treat those deficiencies or underactive thyroid, then the person's memory can return pretty much to normal. So when we also talk about delirium, so you will hear within the health system the importance of the 3 Ds, so dementia, delirium, depression. And so delirium is more of an overnight phenomena. They acutely become unwell or confused, and typically, or usually it's caused by some infection or some organic abnormality which underlies it. And so delirium is thought of as a medical emergency, and it's important that people seek help straight away. Is there anything else you want to add to that?
Yeah, and it's so common. Like the clients that we have, we are informing whānau when there's a sudden change in the person. Sometimes they'll ring us and they'll say, oh, they're very different, they're more confused, or they're sleeping a lot, and it's not their normal confusion. So that's when we say you need to get them to the doctor as soon as possible, straight away, to have them assessed for any underlying cause. Generally, often it's a urinary tract infection, which is one of the most common things, I think, for
a delirium.
Yes, for a delirium.
And you reminded me that a person with dementia will have a much lower threshold for developing a delirium. So someone who is fit and healthy in their 30s or 40s, it would take a severe infection for them to become delirious and acutely confused. But someone with a dementia, it might be something like a urinary tract infection or even constipation or pain could tip them into a state of delirium. And also with depression, you can get coexisting depression with your dementia, particularly if the person responds to the dementia by withdrawing and doing less, not socialising. They probably are at greater risk for developing a depression, which can then speed up that cognitive decline. And it's really important that if we think someone has got a coexisting depression with their dementia, that we want to try and do something about it, because there's only so much we can do about the dementia, but we can actually treat depression aggressively and get that person better, and that will result in improvement in their cognitive function, but also their quality of life.
Yeah. And that withdrawing from society and social activities is such a common thing when people are either not sure what's happening or initially diagnosed, and the difference it makes when people start to get supported from a dementia organisation, understand what's happening, and then get the confidence to join groups or go out and do their normal activities in the community, can make such a difference to that withdrawing.
I think, thanks Tony, I think comes to mind too about getting assessment early is that there's more than one example I've been aware of in the past where people have had a brain tumour. So in fact, unless that's eliminated, it's on the list there in terms of, and you don't want to be, you want to know what you're dealing with, which is basically what you're saying, Darren. If you're looking at screening someone, assessing someone who appears to have dementia-like symptoms, you've got to rule out other things which are imminently treatable and curable, because otherwise the person is, you're not doing them a favour at all.
So the assessment typically would be seeing your GP, making sure that you have a physical examination, neurological examination, blood tests, urine test, and if needed, referral to a specialist. We would normally do brain imaging, so a CT or an MRI scan of the brain, but usually, most of the time, that brain image is reasonably normal. Very rarely we would find something atypical, like a tumour.
Not common.
There are other conditions which might present with dementia-like syndromes, like normal pressure hydrocephalus. So that's where that early on they would have problems with their gait and urinary incontinence. The brain imaging is really to rule out the weird and wonderful, and we don't diagnose dementia on the scan. It's more of a clinical diagnosis, understanding the changes over time, what might be causing it, and the pattern of cognitive impairment. The risks for developing dementia really relate to what you do in your 40s and 50s. So dementia in some ways can be preventable if you try and remain active and healthy and exercise and limit your alcohol use in your 40s and 50s. So we think that someone who develops dementia in their 60s or 70s begin to have changes in their brain in their 40s and 50s, and over time that continues and then becomes clinically apparent in their 60s and 70s. And in the future, what I understand is that treatments will be aimed at people who we can predict in their 40s and 50s will develop dementia 20 years later, and then giving them treatment to try and slow down that process in terms of brain changes over that 20-year period. So being, regular physical exercise, using your brain, the saying, use it or lose it, remaining stimulated, socialised, lifestyle factors can be really useful at reducing your risk of developing a dementia.
And keeping your numbers stable, your high blood pressure and cholesterol.
Yes, that's right. That's important. So there's a bit of bad press about medications which lower your cholesterol and things, and people worry about them, the side effects. But my understanding is that the statins actually significantly reduce your risk of developing a dementia. So not only does it reduce your risk of having a heart attack, but reduce your risk of developing dementia long term.
So that's your regular GP checks.
That's right.
Yeah.
Yeah.
Yes.
What we're going to talk about next?
So I was, how often is, what's the percentage of people with dementia that have hallucinations and false beliefs?
So if we just talk general terms, so we're moving into behavioural and psychological symptoms of dementia. So that's abbreviated to BPSD. And it's really important to acknowledge that the behaviours and the psychological symptoms of dementia are really the problem area, which makes it harder for the carers, and typically means that people start to struggle caring for them at home, and they might need to think about higher levels of support. Moving someone from home into age residential care is usually a last resort in lots of ways, but typically it's the behavioural and psychological symptoms which mean that they might have to consider alternatives to home. So there's lots of different types of BPSDs. Psychotic symptoms, we typically think that approximately 50% of people with dementia at some stage during the course of their dementia will have psychotic symptoms.
That's not high, isn't it?
Yeah, and so that might be, frequently it would be delusions. So I would talk to people about, with dementia your memory's poor, so you lose things, and then the person who is developing delusions will go the next step and be convinced that someone's come in and stolen them. Or they might be convinced that people are neglecting them, not looking after them properly, that they are against them, that they're trying to move them out of their home or steal from them. Hallucinations, seeing things, hearing things, are actually quite uncommon unless you've got certain types of dementias like Lewy body dementia, where you're going to have a lot of higher rates of visual hallucinations. And again, like I said, with depression coexistent with dementia, psychosis coexistent with dementia, it's important that the person comes forward for assessment and treatment, because we can actually treat psychotic symptoms reasonably well, just like we can treat depressive symptoms reasonably well in the context of dementia.
Can you tell us much about capgras?
Capgras delusions?
Yeah.
Why do you ask about that?
Oh, I just was reading up about it, and I just thought it was like fascinating and amazing.
Yeah, so capgras delusions is an odd delusion where the person thinks that someone they know has been replaced by someone who looks identical. So they're not Carol, but they look like Carol. And so usually associated with problems with the temporal lobe. Not that common in dementia, but can occur. And there are, occasionally you'll meet someone with atypical dementia who might have significant visual hallucinations in the context of Alzheimer's. But the other BPSDs frequently, person might have nighttime disturbance, so they might not sleep very well. They might be up in the night. They might think that when they wake that it's morning time, when actually it's only 2 or 3 in the morning, and they might get up and get dressed and have a shower and be very disruptive. You also can see high rates of agitation, which is a really umbrella term which describes all kinds of behaviours, from being restless and fidgety and pacing to asking the same questions over and over again, to hoarding things, collecting things, sticking them in their pockets, or hiding things, to becoming aggressive and threatening. What about some other BPSDs, Carol?
I'm just thinking it come to mind my sister-in-law who lived with us for a while, and classically that's what was happening in terms of what you were saying. She was convinced of certain things, and then was a combination of that and not, some people accept it with a little bit of, the acceptance of it is so she had trouble accepting it as well. So when these things happened, it it was very disturbing for her. So she ended up actually needing inpatient treatment for a period of time because it was, that combination of paranoia and also, she was physically hurting herself. So it's distressing for family, It's so and I guess the good thing about that is certainly when she was in care the last 2 years of her life, they eased off. It was pleasing to see that they weren't, the duration had a natural way of tailing off, and we didn't see her that way for ongoing. It was and I think that's possibly the case if they come, even if they are quite serious, the BPSD, they often tail off.
Yeah, so I always say to people that dementia is an evolving picture. It never stays the same for long. When I say long, it might be prevalent for 3 to 6 months. So someone might be distressed, or the carer, the next of kin might be distressed by a certain behaviour. But if we can work together and think of all types of kind of treatments, psychosocial interventions or supports, medications are typically last line. Then if we can get through that, then things tend to soften or change. At the same time, a new behaviour may become apparent.
Yeah, and I think that's right. And I think it's for our service, given that people can be in the community for sort of say 8 to 10 years of the journey, it's that navigation role that people can touch base. Oops, something else has changed. So you don't see them you might not see them for months or even a few years. Oops. So I guess the reassuring part of our service is the person who knows the story, who knows their background, they can touch base and say, oops, and if it's something serious, then there's an ongoing referral being done to specialist services while the behaviour lasts, and then they come back into that circle, so that the value of at least having someone they can touch base with. And I was saying to Tanya before, we're cheerleaders, you're doing a great job, oops, things have fallen off, let's see where, how do we problem solve this together? Oops, there's a hospital event, and it's people having that ability to obviously on the journey by themselves, but they can touch base with when they need it, because it will happen. You will need. It's unusual to have a completely smooth journey. It happens, which is great, but not always. I think just something that came to mind when you were talking, the link between Parkinson's and dementia is quite strong, in terms of one affects the other, or they affect the same part of the brain. Can you just give us a little bit of
So Parkinson's is Lewy body disease. Within the substantia nigra, so that a certain part of the brain which will then affect movement. And interestingly, there's different types of Parkinson's disease. So some Parkinson's disease will typically just have a tremor.
Yes.
And they won't have gait or axial problems. So if someone with a Parkinson's disease has significant gait or axial problems, when I say axial problems, I mean like with their torso and things, would mean that the Lewy body, the Lewy bodies are more widespread throughout the brain, rather than someone who just has the tremor. And so dementias with Parkinson's disease are more associated with those more widespread Lewy body presentations, but the rates of dementia can be quite high in Parkinson's disease, and that can be a little bit more challenging to treat. But the medications that are licensed and funded in New Zealand, cholinesterase inhibitors like donepezil or rivastigmine, galantamine, they can be quite useful in someone with Parkinson's disease, particularly because Parkinson's disease you can also get with these Lewy body, widespread Lewy body pathologies. So that now we're moving into Lewy body dementia. They will have falls, fluctuations, visual hallucinations, and cognitive decline. Those cholinesterase inhibitors can be quite useful at treating the hallucinations as well as the cognitive impairment. And with Lewy body dementia, we've got to be very careful with certain types of medications. They can be quite sensitive to medications, particularly antipsychotics. So another reason to come forward for assessment so that we can be clearer on the type of dementia, and then that can help us understand going forward what will be helpful, and for some dementias what will really not be helpful and potentially risky.
Okay.
When you were talking about CT brains, I've sort of gone back a little bit. I wondered whether you could talk a little bit about what other things I can see on the CT brain, like with vascular changes or something like that.
Okay, so vascular changes we would see a lot more on an MRI scan.
Oh, okay.
The difference in quality, image quality is quite significant between a CT and an MRI. But at the end of the day, it's about what we're trying the objective of the image, of the scan. So with dementia, typically we might think of imaging the brain because we want to rule out the weird and wonderful. We want to maybe understand a bit more what might be the cause of the dementia. So as I said before, typically with Alzheimer's type memory problems, the scan in the early stages will be completely normal. And then with an MRI scan and occasionally with a CT scan, you can look for regional atrophy. So with Alzheimer's it's more temporoparietal, and with vascular type problems then you would usually see strokes or TIAs, or an excessive burden of what they call white matter hyperintensities. But yeah, the scan doesn't usually change the diagnosis or the treatment. And so I'm not rushing to do a scan. I think it's more about encouraging the person to come forward, to have a discussion, understand what they're struggling with, and then if we can assist them and give them some feedback as to what we think is going on. I always try and reflect back that we're trying to give them good information which can help them make good decisions. It's about empowering them, and telling someone that I think this is a dementia syndrome. It's not a nice thing to do, but typically the people who come forward for assessment have an understanding of what's happening, and it's very rarely am I ever saying something that they haven't already thought of or they think is a possibility. And then it's about encouraging them to use that information to make decisions, whether that's appointing an enduring power of attorney for health or property or both, starting to think long term about what they want to do. I typically tell people to go on a holiday.
Definitely.
And then really talking to family and making plans together as to what they think is the best thing to do going forward. But a lot of people with a dementia continue to lead active and reasonably full lives. I guess their priorities change in some ways.
And then just with the family, when they understand what's happening with that person, they can support them more to live the lives and continue to doing the meaningful activities they did with it. They just might need a little bit more help.
Well, I always encourage people to do the Living with Memory Loss program.
Nice, yes.
So and for the next of kin and the family, I think that's a hugely beneficial course for the not for the patient but for the people who live with the patient to kind of understand dementia and what the future might
Yeah.
bring.
So
Again,
currently with dementia, our northern region, we run a carer education program
Yeah.
via Zoom, and it runs over 6 weeks, and I think it runs about 4 or 5 times throughout the year, revolving, so people can access that if they contact their dementia organisation, and they can get registered through that way.
Online option.
It's an online Zoom option.
It complements the face-to-face.
Yeah.
I think I'd just like to put a plug here too, like you talked about the value of early assessment as well, and just from a very practical point of view in terms of getting affairs in order, is that how vital EPOA is these days. You know, people, having a will is kind of important, but the enduring power of attorney is just, it's crucial. I mean, in terms of you don't get into a residential facility now without it in place, and it's something that sometimes people, if you leave it too long, the person with dementia hasn't got the capacity. So it's one of those things that it's not a clinical treatment, but it's one of those things that we kind of like to mention as early as possible. Well, I think these days, if you buy a house and get a mortgage, they're saying, you know, have your will and have your EPOA, you know, in terms of the. So, but it's something that, and it costs, of course. That's the other barrier. So
that cost is a lot less than if you leave it too late.
Good
and
point.
The person can't appoint an enduring power of attorney. Then they've got to go through the family
The
court.
whole process.
So that smaller cost in the earlier stage, I think, is well worth it.
So important, and also appointing a successor. Is so important. So having that backup person in case something happens to the current attorney for the EPOA.
I'm sorry, just jumping a little bit too, and it's come to mind because it's when you're talking about the journey and where people are maybe people with dementia are getting quite distressed about something. You know, there was a place, I guess, if you look historically, you know, some kind of pharmacological treatment of that, whereas in fact, you know, whether there's medications that can treat things like that, but with dementia, my understanding is now with it's non-pharmacological you know, strategies are what you first employ before you start. You know, it's someone likened it to two-year-old tantrums. You don't give 2-year-olds haloperidol, you know, because they're tantruming, and it's kind of it's over time. And in fact, now one of the quality indicators for residential care is you're using as little as possible. And if you do have to use it, it's small and short amounts, you know, times, duration.
Yes.
But there's certainly been a trend there that is a good trend, because why do something if it's not going to work as well as non-pharmacological, but it could be harmful. Yeah. So and I noticed certainly in hospital where I'm working too, there's a lot more policy and structure around that kind of
Yeah, you're right. So the first line is psychosocial. Well, the first line is assessment, isn't it? So,
yes, that's right.
With someone with an advanced dementia, agitation might be due to pain.
Yes, of course.
So considering all possible causes for the problematic behaviour or psychological symptom, and then thinking about what might be underlying the behaviour or the psychological symptom. It might be understimulation, it might be a lack of access to the outdoors, it might be, as I said, pain or
constipation.
That's right. Or
dehydration.
And then a psychosocial intervention. We would always try that first, and medication would be last resort.
Yes.
Again, you know, thinking about those possible comorbidities, depression, delirium, psychosis, that kind of thing. The other thing that we haven't spoken about is the importance of stimulation and socialisation, which is an important treatment for dementia, and you know that TV program, the restaurant that makes mistakes, which I think is great.
Yeah,
so good.
It is good.
And I see the people with cognitive impairment, they almost kind of blossom as the show goes on, and I think that's about stimulation and socialisation, which is an important treatment for dementia. And that's where kind of correcting sensory impairment is also really important in terms of helping the person with dementia, so hearing impairment or visual impairment. And you often hear the story that the person's sensory impairment precedes their dementia. So, you know, someone who has significant deafness will be much more at increased risk of developing a dementia over time. And my way of thinking is that deafness, that uncorrected deafness, you know, results in understimulation. You're not using your brain or your cognitive function as you would do, and so that then is a significant risk factor.
Yeah, and we've interesting. Our services, there was a review, a lit review, completed a few years ago by Matthew Croucher, and it was basically, you know, what do we know about what works, which is really good to do. Any organisation that's working with people with dementia, in terms of what are the best recommended strategies, and these things that probably intuitively, when you worked well, it's just good to have your hand on your heart and say, well, actually, you know, we're now able to be quite confident that these are the types of strategies that we need to employ, and we don't reach necessarily. I mean, people might think in their own head, reaching for a medication to calm someone down is the easy option, but it's not really the best in terms of their well-being, etc.
And just like going back to that socialisation and doing meaningful activities. It's a person with dementia needs to feel valued just like any other person, and a way that we feel valued is by doing meaningful tasks, and that includes doing household tasks. So you know, just because they might put the cup in the wrong cupboard or anything something like that, get muddled up with the dishwasher, it's still encourage that person to do it and support them to do it. Like have a label on the door that says cups and plates and knives and forks, to help that person still complete that meaningful task and feel valued.
I always encourage an early discussion about the other treatments and services that are available, like day programs.
Yes, absolutely.
I think day programs, you know, a lot. Every time I mention day program, someone will grimace or show a face, but actually day programs can be really useful. They, to the person who may have lost some of their language function, in a day program they might be able to do things that they wouldn't normally do at home, so arts and crafts, or
for sure
a music group, or socialisation or games, a walking group, so they're able to be stimulated and socialised, and at the same time the person who's caring for them, you know, pretty much all the time, on the day that their loved one goes to the day program, they have some time to do something that they can only do when, you know, they're not caring. So day programs are a great resource.
They're brilliant.
Helps destigmatise too, isn't it, in terms of the just awareness raising, and that it's
and
very valuable.
It increases the support for the person who's caring for the person with dementia. You know, even if it's a drop off and a pick up, you know, they're still talking to people that at the day program staff who they develop a relationship with and feel supported, even if it's just a sounding board for something that might have happened that week or that day.
Because it's just not normal to be being with one person all the time. No. Even if it's with your husband or wife. That is not normal.
Regardless of whether you've got dementia, it's bad for you.
It is bad for you. Like,
too much quality time.
Other people.
Just in terms of a slight topic change, the research and the fact that what we're doing at the moment is you know, that pathway of the condition where it's recognised, it's assessed, there's recommendations for treatment, there's a journey that can be helped navigated. Realistically, how can we anticipate a cure? Are we talking, you know, it's not next year, it's not, you know, I mean, unless there's a breakthrough, it's not imminent, is it, on the horizon? So what we're doing at the moment, we're doing the best we can, and we need to take credit for that. and we'll be the first to stand up and cheer if there was a cure, but it's not this decade. What's your best guess on that?
I'm probably not the best person to answer that question, but
Sure.
I don't see a cure being
No.
available, for some time.
Yes, yep.
I think
Keep doing what we're doing.
keep doing until we can confidently detect people who are going to develop dementia in 20 to 30 years' time. We won't be able to
Move the dial much.
That's right.
Yeah, okay.
Because when we're seeing someone in their 60s, 70s, and 80s, unfortunately, we're 20 or 30 years too late to be able to cure it.
Yes.
But I'm confident that at some stage we will be able to,
Slow it down.
identify people in their 40s and 50s who are more likely to develop dementia, and then putting in steps to really reduce that risk.
So you'll drive something else. Slow it down enough that you'll drive something else.
That's it. You mentioned that sometimes I talk to patients about this, and that they're very hesitant to come forward for a diagnosis of dementia, and I say to them when we talk about the diagnosis and what the future might mean, as I say to people, we get into a bit of a fixed mindset that this is going to be the be all and end all, but no one knows what's around the corner.
No.
Yeah.
And so you might be run over by a bus.
Yes.
Or
Yeah, so
you
true.
might something completely
Other health
unexpected
event.
might happen.
Yeah, that's
so
true.
we can't predict the future.
No.
And it's all about empowering the person, giving them good information so they can make good decisions going forward.
Yeah, totally. And live for the day. I think that's what dementia helps us.
Yeah.
It's certainly helped me be like that, because you've actually got to embrace the actual day, and who knows what's going to happen tomorrow. Yeah.
And it's look, if it is with us, it's if we can, if people are more aware of it, and I guess there's a fear about and then sometimes your friends don't come to visit you. I'm losing my marbles. That goes kind of connotations. So that that if what we can do is say, well, you don't get to pick. It was a lovely phrase at a conference I heard once, and the lady said, you don't get to write the script, but you can play it well. So and it's kind of been a bit philosophical about the fact that you don't you don't get to pick. So it's and I guess that's about personal values and about how people see life, but brings it all to the surface with a diagnosis. And
I can see some people that you meet early on in their journey of dementia, and you might meet them 3 or 4 or 6 or 7 years later. I'm still amazed that person's personality continues to shine strongly through their dementia.
Nice.
So my father suffered with dementia, Parkinson's disease, dementia, and it was very difficult to gradually lose him over time.
Sure.
And I guess that's the other thing about that diagnosis, is that it does help the carer or the family understand what's going on, and if needed, they can access help and support as well.
Yeah, absolutely.
Because it can be very difficult.
Yes,
it's slowly losing someone.
That's right. Yeah. There's one of the reasons this podcast would develop was Jack is staging a show in November, and the title is "I'm Still Here."
Yeah.
So what you're saying is what you see in a clinical setting is that there's that spark that is the person is, and it can come through sometimes quite spontaneously.
Yeah.
And that's them. So that's kind of that's nice. That's a nice feeling, I think. Yeah.
Great.
We've been talking for quite a while.
Yeah. I think we're done, are we?
45 minutes.
Yeah.
That's pretty good.
That's pretty good.
Yeah.
What we might do is I'll just get you to just do maybe a quick wrap up.
Sure.
All right. How should we do that?
I don't know.
Do you just want to say, just want to do that? Just we don't have to do all three do it. If you just say thank you for your time, and it's been a useful conversation. We hope people find it helpful.
Yeah. Okay. Let's do that.
Yeah.
When you're ready.
Well, thank you very much.
Thank you, Darren.
And I hope our discussion is useful and helpful, and I certainly would encourage anyone within the Lakes area to contact these lovely ladies who are, great resource and very skilled and very approachable.
Thank you, Darren.
Thank you, Darren.